Welcome to Dental XP. I'm Dr. Maurice Salama, and I'm going to take you through today immediate replacement of a hopeless fractured maxillary central incisor. We're going to be showing you how we utilize CT scan technology to plan the case from the size and shape of the implant all the way through to abutment selection and also the location of the final axial cuts in terms of screw access and abutment and temporization profiles. What you're seeing here on the CAT scan is how the implant is going to be in the bone, and we're going to protect it by at least 2 millimeters. We have a great ridge for replacement of this tooth, and you're seeing here it was bonded in temporarily, tooth number 8, and it has a vertical fracture. And you're seeing the preoperative view the day of surgery. We take a look at the health of the tissue, the thickness of the ridge, the vertical interproximal height of bone on the adjacent natural teeth, and this superimposes the 3D section onto this for planning. We know that we can place the implant so that it is placed towards the palatal. And the first thing in replacing a fractured tooth is to really get the tooth out with minimal trauma to the surrounding bone. And one of the ways that we like to do this is with a device called an Easy Extractor from Titan Instruments. And what we do here is we time the extraction screw. We actually drill into the root canal system, and then much like we place an implant, we use a self-tapping extraction screw placed into the remaining tooth structure that is subcrestal, and then we fit a extraction tray on with thick putty mix to protect the adjacent teeth while we then apply the extraction forceps. And what you're seeing here is the delineation and space underneath the gingiva and the line for the extraction forceps. This is actually a screw-based system so that all the force is being applied through this system coronally and vertically, and this is what the site looks like approximately 5 minutes later. We simply extracted the tooth without any pressure laterally or on the buccal plate of bone. This is the tooth that was fractured being removed, and you can see how that extraction screw was able to engage the fractured segments and remove it without trauma. And then utilizing a surgical guide to place the implant according to the CT scan 3D treatment plan that was done so that the screw axis would be towards the lingual and we'd stay away from the buccal plate by approximately 1.5 to 2 millimeters. That jumping distance allows for bone ingrowth, and we know this from the literature that it has a high rate of success. I'm placing in this case, a Zimmer tapered screw vent implant. It's going to be a 4.7 by 16 millimeter implant, and we harvest the autogenous bone from the drilling sequence and utilize that bone to graft the space that we had left on the buccal axis. So this is internal socket grafting. We pack this bone, autogenous bone. You can also use mineralized allograft bone if you'd like. And you can see we've packed this bone only against the buccal wall, that area that had not been engaged during the drilling sequence. Now proceeding with implant placement. This is again based upon the 3D scan and where that tooth is going to be, and then inserting the 4.7 millimeter tapered screw vent implant, hugging the palatal bone, and compressing the autogenous grafted bone against the buccal wall of the socket. And this is what it looks like. Day of surgery, it looks like we've barely insulted the surrounding tissues at all. And we want to make sure that we place the implant below the gingival margin by at least 2 to 3 millimeters. And again, you can appreciate the accuracy of the guide in placing this implant, and we know now the head of the fixture is appropriate depth. The next phase is what to do with this implant. We can temporize it at the time of surgery, and this is utilizing the new HLA contour abutments from Zimmer with snap cap componentry. This is the analog and the impression cap that goes with this system. And you can see it has a natural anatomic contour. And this is what the snap cap looks like. This is the day of surgery. You can snap it onto the abutment, and you can send it off to the lab for the fabrication of a temporary, or in some cases even a final restoration. You can see how this was all taken and derived from CAT scan 3D technology. Now this is one option. We can pick up this in the impression and then secure the analog onto the impression cap and send it off to the laboratory. Or we can also utilize the temp-based cap and pick up and reline a temporary restoration. Or we can go back to the old way of doing things and just wait till second stage or 2 months later and place in a healing abutment. This is something we've been doing for quite some time. Many of you out there use this procedure quite readily, just placing a healing abutment. The only problem with a healing abutment is its shape is conical and flat. It does not follow the natural scallop of the gingiva. So if I was to take this out and replace it with something I think it's even better, would be a natural contoured clear cap that is hardened plastic material and that gives you the interproximal shape for support of the papilla. I believe that this is a much better alternative to a staged healing approach than the old tried and true circumferential rounded flat healing abutments that have been available with most systems. You can shape this if you want with a burr, and you can see how it supports the papilla interproximally during the healing phase much better than this more historical method of just a traditional healing cap. This is what it looks like at approximately 6 days. You can see how that healing cap has supported the interproximal walls and the papilla height, and yet was rounded on the buccal and diminished contour on the facial, so it did not cause recession of the facial tissues. At approximately 8 weeks, I can remove this healing cap, the contoured healing cap, that mimics the shape of the HLA contour abutment that you were going to place now in at the time of 8 weeks. And these are the components for this part. It's all snap cap componentry. The HLA contour abutment being inserted approximately, in this case, 2 millimeters high subgingivally off of the head of the fixture. You can see that it has a snap cap and undercuts on the coronal aspect, and we can utilize a temporary cap to pick up the margins once we fabricate our temporary restoration. This can be done in the mouth, or it can be done on the previously made laboratory model. Remember, we did that at the first surgery. So this really expedites things very nicely. If we want to take an impression to get a new fit, a accurate soft tissue model, we can do this again, just like we did at the first surgical procedure. Again, snapping in the analog of the HLA contoured abutment into the impression, and then sending this off to the laboratory. So this is what it looks like, what you've just seen. This is the live procedure. This is 8 weeks post-op, basically taking you through what the restorative dentist would go through in a procedure like this. Unscrewing of the healing abutment, you can see how it's maintained the contours of the soft tissue, and you can see how it's shaped, flat contour on the labial and interproximal heights for support of the papilla. And here you're seeing just the soft tissue drape that has been maintained during the 8-week healing time. Look at the shape of this, how it's been maintained, and this is what we leave in the mouth and take out. You can see that that shape has been maintained quite nicely. To receive the HLA contour abutment, you can see this has a natural contour and anatomy of a chamfer margin that's lower on the facial aspect, and it goes more coronal as it transcends from the buccal to the lingual. The temporary cap now fits directly over that, could be used as a comfort cap, also snaps on, or it can be utilized as a coping for the reline of a temporary restoration. And you see us going through the process here. This was the temporary that was given to us by her restorative dentist, and I can reline this rather easily at 8 weeks with not much to do in terms of time. It will capture the margins, and I'll be able to reline it out of the mouth. Screwing this down, just hand pressure. This allows us now, we can leave this in the mouth, never having to take it out again. One of the nice attributes of this HLA contour, anatomic contour abutment, is we can put it in once we decide on the depth of the margin. We can then snap in. This is something that the restorative dentist can do, or the surgeon, because it is rather easy. And this is what your restorative dentist would be able to do, is just basically take their impression of the soft and hard tissues and pick up this impression cap and send it off to the lab for them to pour it up with the analog. Now this expedites things quite nicely because the abutment that we place can stay in the mouth, and that's a big advantage biologically because it maintains the bone without having to unscrew and screw on new parts at each visit. So this becomes basically a screwless system. The restorative dentist, if you're the surgeon, if you place and select this abutment, the restorative dentist doesn't have to play with drivers or screws because this never has to be removed from the mouth. This is what it would look like poured up in the laboratory model. You have a chamfered margin and you have a soft tissue rendering of what's in the mouth. And you can also use a Essex style temporary retainer if you want to, and hollow it out if you're the surgeon and don't want to reline the abutment, and that just goes over the abutment, and it's a removable appliance. Just another way to do that. One of the things that we have to do with these abutments at times in the lab is form a reduction coping to make sure we have adequate incisal clearance for the final ceramic material. Here we're seeing a reduction gauge of approximately 1 millimeter. And we now utilize the temp base cap to be used as a reduction coping intraoperatively. And this is what the restorative dentist would have to do in the mouth. We place this in the mouth the same day. This is the temporary after the reduction coping has been utilized. And you can see now at approximately the day of surgery, we utilize the temp base reduction coping to reduce the abutment in the mouth. This is what it looks like after reduction. And this is what it looks like right before cementation. Now, because we have a snap-on component, we don't have to cement this with traditional cement. I use acromycin antibiotic paste, so there's no cement introduced in subgingivally to cause inflammation. And this is what it looks like the day of the second stage procedure. At 2 weeks post-temporization, I'm just going to take you through what it looks like. This patient comes back in. I'm going to now cement it with conventional cement. You can see the tissue is healed enormously well. And you can see the contours that have been developed by the temporary subgingivally. This abutment never has to be removed, so this becomes a screwless system. And you can see the tissue contour, the papilla support, and this is what it looks like at approximately 2 weeks after temporization. I hope you enjoyed the video, and we look forward to seeing you again.